Hello, my name's Ed Pavlik. I'm in Lexington, Kentucky.
Frank Lawson, London, United Kingdom.
I want to welcome you to another edition of GYN ONC Garage. This is our August edition, and this is time we're going to look at a paper that has to do with aspirin use as a chemopreventive against ovarian cancer. This paper was published in a very good journal. It has a multitude of very well-known authors, and its title is Modification of the Association Between Frequent Aspirin Use and Ovarian Cancer Risk, a meta-analysis using individual level data from 2 ovarian cancer consortia. What you have to realize from this paper is that it's done as a case control study and as a cohort study, namely that people in both of these pre-existing groups were selected out, for use in the current publication. So what I'd like to point out to you is that the case control studies start with the disease, while a cohort study starts with a cause to effect type of phenomenon. In red and green font, I've identified what really is going on here, and that's that the case control study has people who were tested whether aspirin usage occurs more in those without ovarian cancer versus those with ovarian cancer, whereas a cohort study tests whether ovarian cancer occurs in those taking aspirin less rather than in those not taking aspirin. So with that in mind, we have subjects coming into this paper for use from the United States, United Kingdom, and from Australia. And, we have a lot of them. There are about 5,800 of these people contributing to the case control study, about 2,600 in the cohort study out of almost 500,000 people under consideration, many of whom did not have ovarian cancer. So we're talking about aspirin. What are the criteria to be included for aspirin usage? It was 6 days a week for more than 6 months. So if you were using aspirin that much, then you were in the study. In the end, their conclusions are that over all comers, there was a 13% overall reduction in ovarian cancer mediated supposedly by aspirin usage. And if you look just at the risk groups, if you had 2 or more risk factors, the aspirin was able to achieve a 19% reduction in ovarian cancer in this study when there were 2 or more risk factors used. If you considered endometriosis as a risk factor, there was no benefit from aspirin. The last thing I'll say about what they found is that although it looks like a 13% or a 19% benefit, it's really the number of people you have to treat with aspirin to get one ovarian cancer event not occurring. So you have to treat about 1,000 people to get one person who doesn't, who's protected against ovarian cancer. That's some substance of the paper. There are several questions that I'd raise that the paper itself doesn't answer. Dose is one of them. We don't know to what extent baby aspirin versus larger dose aspirin it can work in this context. So the question there is, will low dose 88 milligram per pill aspirin, baby aspirin work? We don't know what the indications in this study were for people taking aspirin. Were there other problems that they needed it for? Is there a selective confounding there? The duration of usage, once again, is a question because they were divided into those using aspirin for less than 5 years or for more than 5 years. And one would wonder why 4 years, 3 years, 2 years weren't also considered. The time since last usage was not at all mentioned in the paper, and we don't know when they quit. And we have no information about genetic variants that might have contributed protective effect with or without mutations to the BRCA genes, for example. So Frank, that's what I have to say about this paper. I think really aspirin is cheap. People can go out and use it. If it's baby aspirin and it may work, there's probably not going to be any harm due to GI bleeds. On the other hand, basically we can expect no further research because a study we use a lot of people to look at whether aspirin actually, in a prospective sense, prevented ovarian cancer. What do you think?
Yes, I wondered whether this was a sort of cardiovascular dose of aspirin, which I suppose is 75 to 100 milligrams or so. So as you've already said, were these people taking aspirin for other reasons, cardioprotective? And also because it's self-reported, and as again, you've picked up on it, how long have they been on aspirin? What the study said was greater than 6 days a week, greater than 28 days a month, or greater than 6 months or whatever. But we don't know why they were taking it, how long they were taking it for. It's a self-reporting group, which is always dangerous in medicine, as we know. One of the criteria is previous diagnosis of endometriosis. Endometriosis diagnosed because they get period pain, or endometriosis because they've had a laparoscopic diagnosis, endometriosis because of ultrasound. And interestingly, of course, the authors suggest that the action of aspirin is anti-inflammatory, and that appears to be the case in things like colon cancer. But the one thing out of all of that they look at that doesn't seem to be associated with reducing risk is endometriosis, and that's the one thing that causes intra-abdominal or pelvic inflammation. None of the others do, as far as I know. BRCA genes, family history, obesity. So they've found something that may be protective, and yet the one thing that it could protect against doesn't appear to be associated with it. 13% is a heck of a reduction as well. I mean, that is fantastic. If that's the case, whoever makes aspirin must be banking it by now, because you know and I know that physicians throughout the world, if they see that adding aspirin, or patients see that adding aspirin reduces their risk of ovarian cancer, they're going to be chewing aspirin big time. And then the side effects of aspirin, the GI side effects, I think will become more apparent. The authors brush it under the table, saying, "Oh, this is cardiovascular type dose aspirin." Yeah, but you know and I know that patients will take more of something if they believe that it's going to give them a benefit. And the other two things I think they're important, that one of the papers that they reference, which I think is reference 7, Zhu et al., looking at previous data on aspirin and ovarian cancer, there's only a marginal significant improvement in outcome, and it's only amongst Caucasians, and it's only amongst women with borderline tumors. And I don't think that histologically borderline tumors and invasive epithelial cancer are the same disease. Borderline is not just a precursor, I don't think, of ovarian cancer. This is not the CIN of ovarian cancer. The other thing that's important is there was a study from 2018 called Aspirin, which looked at similar evidence for aspirin and the reduction of numerous cancers. And actually, in the placebo group, the incidence of cancers was less. In other words, the aspirin taking group, the incidence of cancer was higher. There's lots and lots of problems with this sort of study. And as you said, Ed, I can't see it getting any further. No one is going to do a huge randomized study on aspirin as an adjunct to all of the other chemotherapeutic agents that we use in ovarian cancer. They're not going to add aspirin, and even if they did, I don't think it would show any advantages at all. It may be good, it may not be very harmful, but I'm not sure this paper really supports the use of adjunctive aspirin in the treatment of ovarian cancer.
Let me get an opinion from you. Consider a person like Angelina Jolie, for breast ovarian. Educated person with resources, a person who's watching her sisters and her mother die of a disease, and that places her at risk for the ovarian breast syndrome. What if that person decided that, what the hell, I'll take this type of thing? Would your opinion be that her education level and her access level to medical care and those type of things really should say, yeah, I think maybe it's up to her to do it? And I hate to paint the picture, but someone who's just really panicking from what they hear us say or what they read on the internet, should they be more cautionary?
I think the Angelina Jolies of the world should have the intelligence and the understanding to put the risks to patients. 1 in 1,000 improvement, or whatever it is that, 1,000 of you have got to take aspirin, and 20 of you will have a severe gastrointestinal hemorrhage. Yeah, that's fine. I understand about how celebrity works, but I think you can't just stand on the front of a magazine and say, I've had ovarian cancer and I think taking aspirin is a good idea. I think that's what the scientists are for. That's what the papers are for. And in a way, sadly, this paper is a little bit like that. Oh, something as simple as aspirin? Yeah, take that, you'll be fine. No, A, it doesn't work in very many people. B, I'm not sure it works as well as it's supposed to. And C, there are side effects which the paper does not address. But you know and I know that people in all over the world will read, this will become available, and they'll say, I'll take aspirin as well. If I was making aspirin, I'm sure that would be a very, very good thing. If I was Aspirin PLC or whoever makes aspirin, I think that's good, but it's not science, it's not medicine, it's wrong.
Sure, I understand. Well, we're ready to wrap it up. We've done another GYN Oncology Garage, and I look forward to seeing you next month.
Take care, my friend.
Okay, bye-bye.
Bye-bye now. Bye-bye now.